All right, well, let's go to our afternoon panel. If you recall last year, our panel of people living with memory loss was probably one of the most well-received panels, really well-received presentations we've done here. And so we wanted to do another panel on a topic that we think is of great interest to many. It's on sexuality and memory loss. And so Tamara Statz, who's a study counselor with us on the Families and Long-Term Care Projects, will be the moderator of this panel. So please help me welcome Tamara.
You're going to hear my voice a lot today, so sorry, or something. All right. So, obviously, we're going to be talking about sexuality and memory loss, and we have a fabulous panel put together for today. I have been so looking forward to this, and these ladies know that because I've been emailing them a lot. All right. It's going to be mostly Q&A, so please use those note cards and write your comments. One of the reasons why we switched to note cards is because you might not want to raise your hand and say, I want to ask this question about masturbation, right? Nobody really wants. So we're going to say masturbation today. Or maybe, right, some people might prefer to do that. So I'm going to give you a little bit of background about why we're doing this panel, who's on this panel, and then kind of some questions to get us started, and then I've got some questions if I need to fill in the gaps, but I'm thinking you guys are going to take care of it. So please write down your questions and raise your hand, and someone will come get them for the next hour and a half. So why is this topic important? So it's actually really neat how this panel came to be. We got an email from Teri that said, I'm dealing with this issue. We need to be talking about it. Not a day or two later, Joe got a voicemail from June saying, hey, I'm interested in sexuality and memory loss and consent and long-term care. Can we partner up in some way? And we thought, did they talk to each other? What's going on here? And so it just really came together. We've had, if you were here last year, you'll recall Virginia was on our panel last year. And so we knew without a doubt she'd be fabulous for this panel. And then I thought, I want somebody who's boots on the ground in the industry, helping in long-term care make some of these calls that are very tricky to make. And through the grapevine, got Catherine on board to do this. So I'll tell you a little bit more about these women in a minute. So it's important because people continue to have sex and be sexual and be intimate. And sex means a lot of things. Intimacy means a lot of things. I think we're going to talk about that a bit today. So, you know, there is kind of this narrative, I think, in our society, in our culture, that doesn't happen. But as we know, it does, and that's okay. And so just, I mean, I wouldn't be a researcher if I didn't give you some statistics. So there's some statistics for you. People are still having sex or being sexual. And there was some interesting different literature out there. So this is from, I'm not going to get this acronym right, but it's the Office of the State Long-Term Care Ombudsman, I think I got it right, of Iowa. So talking about federal law, individuals residing in long-term care are afforded multiple rights, many of which are relevant to sexuality. We might not realize this. These rights include, but are not limited to, the rights to privacy, confidentiality, dignity and respect, the right to make independent choices, and the right to choose visitors and meet in a private location. The room got the quietest it's been all day. One of the reasons why I think it's really important we talk about this topic is because it's taboo, right? It's kind of taboo to talk about sex in general. I think we do have this narrative that older adults, oh, that doesn't happen, but it does, and that's okay. And then when we bring in the topic of memory loss, then we can get really into the weeds of, well, what is consent? What if they don't recognize you? What if they live in long-term care? We're going to talk about all of that. So it's important to talk about it. I do want to note, this is just the start of the conversation. We're not going to cover everything today. This is not, I think in any of our presentations, we're not going to be all-inclusive of everything we could cover on any of these topics. It's not really how it works. Nothing is that simple. So just to note, this is the start of a conversation. And understanding that sexuality and sexual expression mean many different things to different people. And we're not going to be able to cover everything, but we're going to cover as much as possible. So who are these lovely ladies we have up here? Well, they're not in the order that they are on the slides, so I'm going to go in the order they are on the slides. June Valleur is a graduate of the medical school here at the U. Woohoo! She did her OBGYN residency from 1987 to 91. She was a professor here at the U as well. She's an ASECT certified sexual health counselor, and she's currently doing online courses through the U to get a certificate in sexual health education. She's the one who gave Joe a serendipitous voicemail saying, can we partner on this? Can we do something about this? And we had a lovely afternoon chat at Starbucks. Virginia Laken, right here to my immediate left, was on our panel last year as well. She's the author of the book Making Love Again. She speaks each year to the second-year medical students at the U of M on the topic of intimacy and aging. She has a couple websites, hopeforcouples.com, which is about intimacy and aging. She and her husband Keith is on the board of the program for sexuality, human sexuality here at the U. And she has another website, virginialaken.com, about her experiences living with mild cognitive impairment. Then third from my left is, I was going to say with the black glasses, but that doesn't narrow it down at all. Teri Klosterman is recently retired from the U of M. She's a volunteer and advocate for the Alzheimer's Association, caretaker for both of her parents diagnosed with Alzheimer's. Her mother died at age 79. Her father is entering his 5th year of the disease since his diagnosis, and she's dealt with intimacy issues with both of her parents while they were in memory care settings. And finally, at the very end on the left is Katherine Johnson. She's a licensed psychologist and former nursing home administrator. She currently provides psychological and consulting services to older adults and healthcare providers through the Associated Clinic of Psychology. She has her doctorate in psychology, specializing in older adult development, and she has a master's in long-term care administration and is licensed as such through the U of M. She has 40 years of experience serving in administrative positions in private and public healthcare organizations, and has served on state and national committees to create or improve healthcare systems. How cool is this, right? So I'm jazzed. So again, here's the directions for what to do. This is old hat to you by now, but if you have a question or a comment, comments are fine too. Write it on your note card, raise your hand. If you need more note cards, you could trade for other goods with people at your table. Maybe you have an extra cookie, I don't know. We're not going to be using microphones throughout the audience, just as we have been all day, and there'll be people coming around collecting your note cards. A couple notes. In your folder, our panel has several handouts for your future reference. So in your folder, which you can look now if you'd like, there are our slides to follow along with, and also there's 4 other sheets of paper that are listed here. And would the panelist who gave me these wonderful, there's 2 panelists that gave me these handouts to include. Would you like to speak about the context of these handouts?
Okay. I can go first. The Sexuality Assessment is something that was put together. This is this one. It's kind of got I think a purple top to it. This was a joint project by the Alzheimer's Association and a university that really can be used by long-term care settings and maybe in any residential setting or even in a family to talk about sexual values and needs. Very simple, very straightforward, but something you can use as a tool as you progress and talk about sexuality. And then also the policy from Kuhn, and this was something that was developed many years ago. For the last decade, at least I'm aware that this has been talked about, but very slowly becoming more available. And there's another policy that someone else offered, but at least this is another policy as a caregiver that you can start reviewing to educate yourself. And also attached to that is a questionnaire he developed about getting us thinking about our own sense of sexuality. And I use these in training sessions with staff in long-term care settings or residential settings. But they're great conversation starters and things that you can bring to actually support maybe the environment in which your family member resides when necessary, or even proactively, I would suggest.
And finally, June.
Which one?
It's you.
You.
That's you.
Okay.
Yes.
So just an intro. Last summer, I did a workshop at the national meeting of the ASEC, which you mentioned is the American Association for Sexuality Educators and Therapists and Counselors. And the topic was taboo. What is taboo in sexuality today? And I submitted Sexuality and Aging, no expiration date. Prior to giving that talk, I had done a lot of reading about sexuality in nursing homes. And I then went to nursing homes in both Iowa and Minnesota. Not a one of them had any policy. And they didn't deal with anything until there was a problem. And so I did a little more reading and found out that this one, this is the Hebrew home at Riverdale, New York. They've had a policy in place since 2001, and it is really great. And so I encourage you to take a look at that, and if you have your family in caregiving situations and there's nothing in place, you might want to approach them with this.
So, at your leisure, those are yours. So, to get us started, and I have one other comment too, since this is a panel. If you're writing a question and you want one specific person to contribute, or you want to make sure that one specific person at least contributes, write their name. If you can, I guess, remember which one they were. Logistically, I didn't really think that statement through, but if you know who they are and you have a particular question you want to assign to them, feel free to write a name on there. So to get us started, as we go through, there's no necessarily rhyme or reason to this, you can take your turns. When you were asked to be a part of this panel, why did you say yes? Why is this topic important to you? Do you want to start?
Sure, I'll start. I'm Virginia, and I was diagnosed with mild cognitive impairment almost 7 years ago, almost 9 years ago now. And why I agreed to be and happy to be on this panel is because I think this is one of the topics. Sexuality in general is not discussed, and I'm pretty sure it's even, if you can be less discussed than not discussed, it is true with people that have cognitive issues. I can speak for myself that, as was said, I have a blog that I write about my journey with mild cognitive impairment, and I also wrote a book about regaining intimacy after my husband was impotent. And I'm happy to be on this panel because I think we need this discussion, and we need to be talking openly about it and helping each other. My husband and I are still very intimate, and I'm going to keep this short by ending this little introduction by saying, when he and I are intimate with each other is a time period when I feel normal.
Well, I accepted because it's my mission in life, not just to teach about sexuality and aging, but often what happens with aging is cancer diagnosis and dementia. And so I wanted to focus on these three areas, and as she mentioned, I'm the one who called her. So when she said, we'll have a panel, would you be on it? And I said, absolutely. I was a PA. I didn't start medical school till I was 41. So I was a lab tech and then a PA, and I do everything late in life. I'm now a university student, and I'm 77 years old. You're never too old to learn. Anyway, I forgot where I was going with that. why I'm here. It's just so important. You know, we have so many difficult decisions around our family when they are in assisted living or nursing homes. And we, as children, think that our parents had sex 3 times because we had 2 siblings. And we just don't want to talk about it. I was lecturing to the medical students several years ago, and I said to them, I'm not going to ask you to think about your parents being sexual. And you could see this collective sigh of relief. And then I said, I want you to think about your grandparents being sexual. And this is the truth. One woman in the second row out loud said, I don't want to go there. And that's probably how most of the medical students felt at that time. And I said, well, if you can't think of your grandparents, think about your grandparents' best friends. Because unless you're going to be a radiologist or a pathologist or something like that, if you're an orthopedist, you're going to do hip surgery on people who've broken their hips or who have arthritis, and they're going to ask you, yeah, I can't do some of those things anymore. Do you have any suggestions? So you better know some answers. It's not just cancer. It's things like disabilities. Sex gets a little bit more difficult as you age, but it can be even better.
Thank you. I'm Teri Klosterman. I've dealt with this in 3 different situations. First was my mother. I was really surprised when she was in a memory care unit where I walked into her room and her twin bed had been swapped out by a double, and there was now a do not disturb placard in her room for her and my father to have relations. But what the home failed to do was to consult with us because my mom was bipolar and molested as a child. And part of the things we had to do before putting her in a home was rescue mom, rescue dad, because mom would think that that man in the yard, my gentle, loving dad, was the abuser. And so we had the conversation with him and said, this is fine, we're happy for this. However, you need to be aware that mom may get scared. And that kind of comes down to what's consent. She may start with consent. She may not have consent. And Dad did not understand the disease at that time. And he wouldn't have known what Mom's behaviors would have been about because she had such a volatile, I think she would have been bipolar back in the days when I was growing up. So that was a very difficult time. Now, Mom died at 79. Dad is 89 now, and he is one of probably 2 real alert, very social men in a predominantly all-women's memory care unit. He's an outdoor guy. There isn't enough to keep him occupied, and the women just gravitate to him. When he first moved in, there was a lady 10 years his senior who was married, and they started a relationship, and it was so sweet. We actually had a consultation between the 2 families because, again, when they're engaging in these activities, you've got vulnerable adult status, and they have to report it to the state, and you've got all these other laws and rules associated with that. But we got together as 2 families, and we discussed this, and we saw what joy that relationship brought to each other. The hand-holding, the cuddling, you could tell when she walked into the room, Dad would light up. I'm going to go back one more time to Mom's situation. Mom also started a relationship with a man in her home. And we told the people, you've got to make sure this does not happen when Dad comes. Because, again, Dad did not understand the disease. It would have killed him to see Mom holding hands or even leaning in. Yeah, and talking about that. Okay, so this woman has now left. Another woman came in, and she has a slight resemblance to my mom. They started again with the simple intimacy out in the open, talking, etc. But it advanced to where they got caught in a compromising position in private. And I've been notified on every time there was a kiss or something. The husband was aware of the situation also. And he was very friendly to me. He was very friendly to my father. He seemed to understand what it was and that it wasn't an attack on their relationship. Contrast that to a good friend of mine whose mother was in an institution, and she started a relationship in there with a married resident. The other family did not want that relationship to continue, and her mother was expelled because the home could not get that relationship under control. And that was very frustrating and a big time of change and anxiety for that family to now try to find another place. My dad has had a wandering lady come in to his room at 11 o'clock at night, and we found out that the home did not have bed checks. They were found in compromising positions. And so again, there's another report to the state. There's been an investigation. My dad is, I guess you could say, kind of on file, even though he's not named in it. I recently moved up to Duluth, or close to Duluth. I'm trying to get Dad close to a place he used to love and enjoy. And he's blacklisted now because they get the report, they find out what's happened. Somebody here said many places don't have the standards. I was very happy to see this because where he currently is, I've asked for the policy. They don't have a written policy. I've gone to 4 different places up north to interview for a new location. I'm upfront with what happens. I asked, have you ever dealt with this? Only one has. None of them have policies on file, though. Yeah. And that's why I called, because it's very frustrating. My dad has no control, really, over his actions, but that intimacy is so important to him. It makes him feel valued and loved. And that's why I'm here.
Thank you, Teri.
And I'm Catherine, so what do you say after that? And as a licensed psychologist for the Associated Clinic of Psychology, we have an older adult division. So I'm among a handful of people who have expertise. All of my studies have been in the field of aging, and sexuality is an important component of that. We come out to the facilities that we're contracted to, and this is often a big topic. And as I had said earlier, only about the last decade have we even addressed it. And we know through some of the research, and I brought at least a couple of books along and even a couple of articles from the Gerontological Society, we're only now beginning to really formulate concepts around what is capacity to consent to relationships, and to understand older adult sexuality, which intimacy and sexuality is everything from a smile to intercourse. And so my job has been to try to advocate for staff training and policy development proactively, but as you're hearing, virtually no facilities have policies yet, don't do a lot of training in this area, and only respond when there's a problem. And so I think in the answer to the next question, I'll talk a little bit about what those problems are, but I share the goal of this panel to try to proactively lay the groundwork so that this important component of our lives for our current older adult population, and as we age, that can be a part of natural human development across the lifespan. You never lose that urge for touch, for intimacy, all the way to intercourse for many older adults. And while that is maybe a taboo or difficult topic for us to talk about, those of us on this panel know that nursing homes and assisted livings and residential settings like that are very similar to a college dorm.
It is.
What used to be said?
And I have to follow that.
Co-ed college dorms.
We kind of touched on this in the answers just now, but if there's anything you want to add in terms of how the topic of sexuality and memory loss has impacted you personally or professionally. Is there anything you'd like to add?
From my perspective, again, this topic of vision your grandma doing this, the thing that impacts me on is, again, seeing the joy my dad has. And there's one case where he and this other woman, she had her hands on his knees, and she was just leaning over and giving him a kiss on the couch. And the aides came rushing in. You can't do this, you can't do that. They were so agitated. And, they've got to learn how to redirect without making them feel bad. And my dad and that woman both, she started crying, and my dad came in and, what did I do wrong? They don't see that as wrong. They see that as something beautiful. Yeah.
I don't have a personal one, but one of my longtime heroes is Sandra Day O'Connor. And many of you probably know the story that she had to resign from the Supreme Court to care for her husband who had dementia. And while he was in the memory care unit, he developed a relationship with another woman. And when Justice O'Connor first heard about this, she was aghast. But what she saw was the change in her husband's personality. He had been agitated, depressed, you name it. And when she saw that change, she realized that it really wasn't about their relationship. It was about an activity that made him feel whole again and like a human being again. And she went on to bless their activity. I'm really sorry to say that Justice O'Connor has now developed dementia herself. But that's just one of many stories, and I'll bet there are people out here who have similar stories.
Obviously, this has impacted me personally. And when I use that term normal, it was very intentional because for a number of reasons. One, there's a lot of things I can't remember. There's a lot of things I can no longer do. I no longer drive. I'm having trouble reading. There's things I can't participate in. Which is not normal, doesn't feel normal to me. But the other part of, and I also think that I'm very open about the fact that I have memory issues, and so many people, I'm from Winona, it's a small community, many people know I do, and I think that when they see me, it could just be in my mind, but I think they see me differently. And one of the things I think they might assume is that there are things I'm not capable of, and perhaps in being intimate is one of those, which confirms maybe what happens in the nursing home as well. For me, so Keith and I participated in the Mayo Clinic habit program. Some of you are probably familiar with it. It actually changed our lives. But when I've been thinking about it, and when June talked about physicians not bringing it up, actually the intimacy was at that time not addressed in that program. I don't know if it is now. We went about 5 years ago. For me, when Keith and I are intimate, not only do I feel normal, but I feel it calms me, it relaxes me, it's meditative, it's healing, and so that's how it impacts me on a personal basis.
Is it okay if I tell the story when I came to talk to you and Keith?
Sure, I don't remember that story, but yeah.
So I've known Virginia and Keith for a long time. And prior to doing my talk in Denver last summer, I wanted to meet with them because they've been dealing with this for a long time. And so one of my questions for them was, so, there may come a time when you can no longer be cared for at home. And because your intimacy, your sexual intimacy, let's be clear about this, sexual intimacy, there's lots of different kinds of intimacy, but we're talking now about sexual intimacy. It's so important to you. I'm assuming that you're looking at the various facilities in your area. What are their policies about sexuality and aging? And Virginia said, I hadn't thought about that. And then she began to think about it and thought about things like, well, what if I become afraid of Keith? Or what if I don't remember Keith?
Yes, so actually I blogged about that too. And I want to actually interview all of the facilities in our area and see what their policy is. But I do remember years ago hearing one of the Mayo doctors talk about having double beds in facilities. And I thought, oh yeah, you've slept next to this person. Keith and I have been married for 50-some years. I've slept next to him for 50-some years. If I go to a facility, do I have to sleep by myself?
Some nursing homes don't even have the ability to buy a double bed. They're not listed in some catalogs.
Yeah. You might have to buy it yourself,
Yes.
right?
Yes.
Mm-hmm. Yeah.
And I'm going to just say one more thing, and then someone else can chip in. But in all of these years that I've been dealing with this condition, I've never had a physician bring up the topic ever.
Yeah.
Now, I bring it up.
Yeah.
But I've never had one of them bring it up.
Yeah. And I can add from the professional side, that's right, that I'm often the person bringing it up or encouraging it to be part of the admission process in a residential setting. And it's like what would be a definition of a good death is kind of a question that people think, well, you'd never ask that, and you'd never ask about sex. And so there's these topics that people don't talk about that we're trying to say. People want to talk about these things, and when I bring them up in my assessments with older adults, they're generally very comfortable talking about it, or they would let you know that's not important to me. So for me professionally, beyond the training, I'm coming into the facilities often when there's three main issues. One, because a resident is being sexual towards a staff member, towards many staff members because the memory loss has caused disinhibition, and the person now is using sexual language or foul language, or engaging in public masturbation, which then might be even just a self-satisfaction or a self-expression of sexuality, but it's not socially appropriate now. And then the third area is when we start seeing relationships between residents or tenants and looking for the soft signs and beginning to assess through an interdisciplinary team and through communication, is this a healthy interaction? Do people have capacity to consent? And then what do we support and provide privacy for? And when do we, all the other strategies like redirection, exercise, therapeutic touch like massage, keeping families involved, keeping the facility medical staff involved, so everybody's on the same page with a plan to support this person for their intimacy or management of a symptom that is a manifestation of their memory loss. And it's generally always environmental. And ultimately, if we talk about it, we can come up with plans. And so those might be some of your questions specifically, but I want you to know there can be professionals that can be brought in if we talk about it. There are guidelines to assess capacity. There's guidelines for environmental strategies like large bed pillows that you can sleep with, or realistic stuffed animals, or overnight visits at home. Multiple ways that we can sustain someone's need for touch intimacy and have everybody on the same page, and then we evaluate and readjust as things change over time. which is exactly what Virginia's trying to prepare for.
Yeah, and one of the things that you mentioned that has been dear to my heart for almost 3 decades now, and that is the lack of education of physicians about sexual health. And for 10 years, Dr. Eli Coleman and I taught sexual health at Mayo Clinic, and we did it here for, well, now, a long time. There is a handout in your packet that talks about what's called the PLICIT model, and it's a perfect model to use if you are a caregiver. It talks about permission, that's the P. So you give the patient permission to talk about it, or the person that you're caring for. The second one is limited information, PLIS, it's okay, specific suggestions, and then IT is intensive therapy. So it's a wonderful model that you don't have to be a caregiver to, you don't have to be a physician or a nurse practitioner or a professional to use. You can actually use that with your parents, or if you can talk to your parents or your grandparents about sex. This is a really pretty easy model.
Wonderful. Thank you. Time is flying by. All right. I have an easy question. I have about 10 questions already. Yep. So I have an easy question I'm just going to answer right away. The name of the book talked about by the woman next to the podium, and that's called Making Love Again. And if you look at the back of the slides of this presentation, everyone's contact info is there, and information on Virginia's blogs and her book are there as well. All right. I think...
So I will comment one thing on our book. Gosh, when did we write that, Keith? 15 years ago or something. So this was pretty radical. I put it all out there because nobody, Keith was impotent, and nobody talked to us about how we could be, he was impotent, how we could be intimate again. And I was so horrified at this that I said, I'm going to tell our story. But we always got the question, well, what did your children think about you writing this book? We're a pretty open family. And I said, well, our daughter was one of our proofreaders. And our grandson, who was 23, has read the book, and because he wanted to know before he got married things that maybe he didn't know. So I think it all has to do, and did I say about us being baby boomers?
No.
So I'm the first generation of baby boomers, so this big bubble is behind me, and I think this is a huge topic with all of these people who don't want to talk about sex.
Speaking of your blog, so when I went to meet June at the coffee shop, we knew we were going to talk about this panel. She's looking on her phone. She says, "You got to read this blog." And I said, "Is it Virginia Laken?" And she said, "It is." So that's how small the world is. It's all connected. So my last question to get us started, which is like we're really into this already, and I think this is a question we're going to get at over the course of these questions anyway. So if you end up feeling like we didn't cover it, you have microphones, so you can chime in. So I want to get to some of your questions here. So here's a scenario. My husband has Alzheimer's, and he's still very interested in being intimate. It's very hard for me because it's so different now. He's rough with me, and I know he doesn't know he is. I don't want to hurt his feelings, but I feel very vulnerable and anxious because it's so different each time. How do I not feel guilty about this? I try to redirect him, but he's very disappointed.
That's really a hard question. And I've experienced this myself. I have a history of breast cancer, and so my vulva and vagina, we're going to use those words, by the way, are like the Sahara Desert, okay? And, when most men become sexually aroused, they can be not as gentle as you would like them to be. And so what's important are to use lubricants and moisturizers and to put your hand over his hand. That is something that works fairly well. You just have to try different kinds of technique, but the hand on the hand is a good one.
Anyone else want to contribute to an answer to that?
Yeah.
I'm trying to think. I don't want to. I know I can't embarrass my husband because I already did many years ago. Keith is very, very gentle, but I'm trying to think. I've noticed my own personality change, and my temper is shorter, and I have always been a rather quiet person, but now I get some good feedback from you. Thank you. Now I find myself short-tempered and shouting, and so I'm trying to think that maybe I would progress that way in my relationships with Keith, but I just can't even answer it because I don't know. I don't know. Because sometimes when he tries to calm me, I'm madder. And sometimes when he tries to calm me, I'm really like, oh, thank you. So I don't know.
And I would reiterate what Janelle Johnson said this morning, is that, once memory loss is in the picture, we know neurologically that's an injury, and the person is doing the best they can. So the person that has to change is us. Mm-hmm. So we have to come, persons with memory loss to me are the smartest people I know, because every time we figure it out, they change the rules. So we have to get creative at what do we do different? How do we try something different that's going to work this time? So I would add that as a professional psychologist, yeah.
Next question. Actually, I got two of them on this topic. Interested in hearing your perspective as it concerns LGBTQ plus older adults and their ability to safely connect romantically, intimately, sexually, and then adding in the component of care facilities in particular.
Well, yeah, we probably both can speak to that. If we think we have it bad as heterosexual folks, the people who are really suffering are our GLBT friends and partners and whatever. Sometimes we have couples in their 70s and 80s who just are terrified of going into a nursing home. They may not be out even in their 70s or 80s. They grew up in a different time than the people who are now teens and 20s who are much more open. But right now at the university in the public health department, they're going to be beginning a study looking at nursing homes in Minnesota and looking at their GLBT policies. I've recently had a conversation with one of the folks over there, and I want to look at all, not GLBT, because that's being covered by another study, but look at all nursing homes in Minnesota and assisted living facilities. There's over 400 nursing homes in Minnesota. I don't know how many assisted living places there are, but they're not as well regulated as nursing homes. We need to find out these things. We need to help them develop plans for how to deal with issues when they arise. So our GLBT community has it much, much more difficult than heterosexual folks.
And I do see us as being those of us who are the professional caregivers or in the field. When I teach classes on memory loss and sexuality, I always have a case study that addresses our sexual orientation and how we address that, and the kinds of uncomfortable feelings that staff have in that area are more sexuality related in general. But that's also something I talk to residents about when I do diagnostic assessments with them, and I am increasingly more fascinated, or just I think comfortable as I ask them to tell the story. I talk about, I'm the person you can tell the story to in a safe, non-judgmental environment. Again, when Janelle Johnson this morning talked about telling the stories, I am really impressed by the number of older adults who will talk about their sexual assault that they never talked about, that they're actually the daughter of their oldest sister that was kept in the family because we never told anybody that the oldest sister got pregnant, and of the homosexuality that was never discussed. So I think as a society, maybe we're being more open about those things, but again, we have to sort of name it and put it on the table. And I do find that nursing homes in general and assisted livings, the staff are trying to be more open, but we've got a long ways to go.
One thing I think we need to bring up is each one of us has a different need for sexual intimacy. Not everybody in their 80s has a sexual intimacy need, but many do, as was shown by that study. The reason I'm taking this online class in sexuality education, I've been doing it for 25 years, but my background is medical. And I had an excellent medical background, and I didn't have a good psychology background. And so I'm learning so much about policy and the psychology of all of this. And it's truly been an education. Yeah, that's it.
All right, a scenario here. So a parent who had started acting out sexually inappropriately toward his aides at the assisted living facility. The burden was placed on us, the family, to change his behavior. I think, Catherine, this is a question for you, about trainings available now to help the staff handle these situations.
Yes. I would say, yes, there is training available, and certainly you could call the Associated Clinic of Psychology, but also, the Alzheimer's Association. There is the Center for Sexuality at the University of Minnesota here. So there are sites, and again, I think it is kind of a battle. I do think that it shouldn't be any different than any other thing. Like, what if the person is, wandering? What if the older adult with memory loss is not eating? What if they have diabetes? Or have pain. We talk about, or wear the same clothes, or maybe won't take a bath easily. These are all issues that there are many strategies for interacting with this person through redirection, exercise, music, massage, other forms of touch, walking with the person. So there really is resources out there. And I would urge you to even, if whoever this person is, I'm fine if you want to contact me by phone or email, and I'll try to be helpful. Many facilities may not have a psychologist that comes into the facility, but we may send this clinic or other, even nurse practitioners, maybe the medical providers, would refer you to a particular person that could be helpful, because there are resources, and it shouldn't be the family's responsibility to resolve the problem. And that's what I do see. The person gets kind of labeled as a troublemaker or a problem, and then pretty soon we're thinking, we can't service your person, you need to move them someplace else. And that is not what clinical standards recommend. Clinical standards talk about assessing the situation, you observe it, what's the possible triggers, can we mitigate triggers or remove the triggers? Let's come up with a plan together with the family, the physicians, the nurse practitioners, the whole team, the recreation staff, the certified nursing staffs, and it's a case by case basis. So if the person's wandering into other people's rooms at night and we don't want that, or that's not acceptable to the other family, then we put we use technology to know when the person's leaving the room, so we can offer them a cup of coffee. And avoid the shame and blame kind of behavior. So case by case, and I'd be happy to talk with the person, we can kind of figure out what might be some environmental strategies that preserve the dignity and respect of all parties. And we do it over and over and over, and it's very possible. And I apologize for sort of the general, we're speaking in general terms, but there are, case by case, we can usually figure out, asking the curious questions. Why is that person always attracted to Mabel? Or why is Dad always taking his clothes off at 7 o'clock at night and then walking around nude? Or why is John always attracted to this female staff member, and making sexual comments towards her? I mean, there's the behavior talks. The behavior is talking. Some need is not being met, and we've got to figure out how to meet that need in another way. Is it all right if I share, Teri, what I said? I said they ought to make Teri's dad the host, like a Walmart greeter. And with his friendly and humorous way, he could be greeting everybody that comes, and we could keep him so busy. We could give him jobs to do that relate to his personality style, and that might exhaust him or give him a role in the facility that other people, that women could be a part of, but not end up in something that we decide is behaviorally inappropriate.
And I really appreciate what all you just said, because again, you're giving me more information. But one of the other things that happened in my dad's case, and again, he's not one that, I haven't been told, masturbates in public or takes his clothes off and runs naked or, aggressively attacks women or anything like that. But I was told at one point we need to get him on some drugs to suppress the urge. And I went and I talked to his doctor first. I said, we don't do anything until we talk to the doctor. And the doctor said, no, because he'll be lifeless. He'll take the life out of my father. And so that's something I recommend too. If that's your option, you do some research through these other facilities first. The other thing is aromatherapy, diversion, other activities are so important to kind of pacifying that urge.
While you were talking, I remembered I kind of paused at the end when I was last talking and said that was it. Well, it wasn't. I forget things sometimes.
It's human.
It's the story. It is the story that we need to hear. One of the studies that I read last semester was the study that looked at men and women between the ages of 75 and 85. And one of the questions that was asked was, on a scale of 1 to 10, how would you rate your sex life? One of the women, and they gave a space to write. It wasn't just one of those on the Likert scale, 1 to 5, or 1 to 10, whatever you choose, said, well, I haven't had sex since 1988, and it's just fine with me, so I'd rate it a 10. So I say that so that we know that not all people have a need to be sexual. And it's important for us to remember that. We're not up here saying that everybody's going to have sexual intimacy when they're 85. No. There's a range. I haven't had sex for 30 years and it's fine with you and it's a 10, that's fine.
Can you speak about how facilities can help married couples with intimacy when one person lives in a skilled nursing facility? And, as if that's not enough of a question, what about ethical dilemmas surrounding intimacy, sex, and consent among couples, married or non-married? What if someone can't speak consent but gestures consent?
I brought along this article, which is from 2015 from Dr. Wilkins, James Wilkins, who really did the best summary I've ever seen of consent issues, capacity. So a lot of what I do is capacity. Now, there's several different sets of guidelines around. I actually ask the person, or we watch the behavior, even if they can't talk, because behavior is meaningful. And you've heard a couple descriptions about if you see the people and they're more relaxed, if you see that they enjoy each other's company, if they smile at each other, if they sit together, if they hold hands, those are the beginning soft signs. And I'll often say, do you have anybody you particularly like here? And they may shake their head no, or I have very impaired older adults, or they'll point to the person, or they only remember them when they see them. And then that's the boyfriend, that's the person they sit with. So it becomes a multifactorial way. But many times, even a person very impaired will say, that's my husband, or that's my boyfriend. And I'll say, well, are you married? Oh, no, I don't want to get married. I don't want to have babies. And the other person will, I said, so do you want to sleep with them? No. Do you want to go to movies with him? Yeah, I like, go to the activities or something. And the other person might say, yeah, we're getting married and I want to sleep with her. And I say, well, what if this person doesn't want to sleep with you and they may have a little bit more capacity? And so we try to tease it out through staff observation, clinical observation, monitoring the behavior. We also look at safety for physical contact and what kind of issues that might bring up. And now we've also got to get the nurse practitioners, the doctors on board. We've got to get family on board. And if everything's a go, we just kind of let the relationship develop as it's going to develop. Sometimes they want to sleep in the same bed, and they have the right to. Nursing homes do have to accommodate, assisted livings try to accommodate, memory care units try to accommodate, and then we have a plan that's documented, then we reevaluate, and many times these little loving relationships kind of fall apart, and then they move on to somebody else. And if they get too difficult, then we sort of reassess. And once we feel the person doesn't have capacity, we say they're not consistent, today it's this person, tomorrow it's the next person, then it becomes the responsibility of the family and the whole team, the family, both families, the doctor, the nurse practitioner, maybe we call the ombudsman, maybe we even consult the corporate attorney for that facility. We may call vulnerable adults just to get this on the record, but I say, it should be transparent, it should be open, and it's a process. We talk and talk and talk and talk. Because there may be an adult daughter, and I've had some adult children who are even physicians who say, over my dead body.
Not uncommon.
And so then we got to back up, we got to talk about this. Sometimes we bring in the whole team and the family and we talk some more. And if we can't come to a decision, then we may do things like put one person way at the end of this hall and one person way at the end of that hall. And it's pretty amazing how they find each other. And the end, yes, the worst, the last decision should be to move the resident, to another facility. There is some facilities that have multiple memory care units, and it's wonderful because then John can go to this one and Mabel can go to this one, but they can be together all day or something. Or one is in assisted living, one is in the nursing home, and we figure out how to get them together certain parts of the day. So again, it's a lot of talking, a lot of transparency. Don't be afraid to bring it in. Name it right from the beginning. And bring in as every expert that you can think about, because then you've got other people, who have your back, who you can talk about this and nobody gets, because that's what we don't like is surprises, right? Like Teri talked about her mother all of a sudden having a double bed for a mother that was possibly accusing her husband of sexually abusing her, and this facility did this without your consent, without the family's knowledge. That, I would say, that's the stuff that you go, whoa. So what would you add?
Yeah, I have a story that many of you may have heard, given that we live in Minnesota. How many of you have heard of the Iowa legislator? And his name isn't important because I can't remember it. Henry Rayburn or Blackburn or something like that. And he and his wife, it was a second marriage for both. They'd both lost their spouses. They got married, and from everybody that was talked to, they had an absolutely loving relationship. About 5 or 6 years into the marriage, she began to develop dementia. And there came a time when Henry could no longer care for her, and she was put in a nursing facility. One night when he came to visit, or late afternoon, whatever time it was, there were no private rooms. She was in a room with another woman that was divided by a curtain. And the woman on the other side of the curtain, after Henry left, said, "I heard sexual noises coming from over there." And his wife lived a bit longer, but in the meantime, her 2 daughters from another marriage and the nursing home charged Henry with sexual assault on his wife. About a week after she died, this all came about. And he was eventually found not guilty because they could not prove that they actually had had sex. There was all kinds of stories about, semen in the bed and blah, blah, but there was no evidence. And so he wasn't found guilty. And I think about how really, really sad that is. Like people that we both know and you have experienced, being sexually intimate with your sexual partner makes you feel whole again. I remember giving a talk to an audience about half this size, and there was one man in the audience. And afterwards, he came up to me and he said, "Thank you for doing this. I had prostate cancer surgery a year ago, and I was able to have an orgasm for the first time last week, and I felt like a human being again." Stories. It's about our stories.
I have a resource suggestion here following the question about LGBTQ plus older adults. It is a documentary. You'll have to write this down. It's a documentary about older adults going back in the closet as they age and as they enter the healthcare system for fear of maltreatment and discrimination. It's called Gen Silent. G-E-N, like generation. G-E-N, space, silent. It was done in 2010 by Stu Maddox. So S-T-U, last name M-A-D-D-O-X. Gen Silent, a documentary. How can the younger generations support the boomer generation when talking about sex and intimacy?
Younger generation. I'm sorry, didn't hear the question.
Younger generation?
How can the younger generations support the boomer generation? God, dare I say millennials? How can millennials, et cetera, who are then Aziz, yep, I know, right? My mom's in the audience today, and she's a baby boomer. How can younger generations support the boomer generation when talking about sex and intimacy?
I think naming it and putting it on the table like you would talk about anything like finances or death or, powers of attorney, power of health. Again, it's it is the Hebrew organization that actually recognized they had 10 value points for aging, things like what is wellness or what is meaning in life. And they realized before they developed this policy or around that time that they hadn't included sexuality. Mm-hmm. So it is like those components of life, which is just a human part of our, biology. And there's many topics we don't like to talk to our parents about, like what's a good death? And how do you want us to manage your finances? And how do you want us to manage your funeral? And, even if older adults will often tell me that they're really ready to die. And the kids say, "Oh, you don't want to die." "Oh, Dad, no, you don't talk about that. They must be depressed. Let's have the psychologist see them." And they want to talk about what's a good death and kind of what, they feel bad about spending their money in a nursing home because they wish they were doing something else with it. So sexuality is the same thing. So I'm going to say, just name it, put it on the table, say, Mom or Dad, do you think there's anything you want to talk about as it relates to your sexuality? And is your sexual needs being met here in the nursing home or the assisted living? Is that something you want to talk about? Again, they'll say no or yeah, it's really tough. So I would say just talk about it, name it.
Yeah. One of the things
I would add, so our children are now 50, our grandchildren are 30, and we also have a little great-granddaughter. I think it's one of those discussions that if it hasn't been common in the family, and now the children are going to bring it up to the parents, I think there's embarrassment on both sides because there's been no history of having this discussion. And now you're going to just oh, okay, yeah, let's have that talk over coffee, you know.
Yeah, that's a good point.
I was in a car accident a number of years ago and had 5 pelvic fractures, and I was immobile for months. And when I went for my last appointment with the orthopedist, I said, oh, I've had wonderful care. My physical therapy was great, but there was one area that was missing. And he said, oh, what's that? And I said, in all this time, nobody ever talked to me about when or if I could be sexually active. Now, out of fairness, I said, I do have to tell you who I am. And I wrote this book. So I kind of knew what to do. And he said, well, you know, I've tried to sometimes bring the subject up, but it's like nobody wants to talk about it. And I said, well, you need to bring it up again. You need to bring it up early, and you need to bring it up again. So here was a physician trying to talk to people who have been injured and delicately brought it up and then dropped it. I think the same would happen with adult children and parents. So I think you have to, okay, then bring it up again, and hopefully you can get there.
A few years ago, my husband and I funded a study on sexuality, aging, and mindfulness. And out of that study, with, of course, permission of the people who were in the study without identifying them, we funded a play. And it was called Sexuality and Aging, No Expiration Date. Every performance was full. And afterwards, there was a question and answer session with the cast and the director and producer and so forth. We always had to cut the questions short, always. And there were so many questions, and it was like, well, are you going to continue doing this? Are you going to do it again? So if there's a play in the area about the topic, you might want to take your family there. I mean, there are ways to bring it up in instances in which there hasn't been talk about sex in the family. And it's for good reason. People are embarrassed. I mean, literally, their faces get really red. I worked with a physician once who I suggested that we might want to talk about sexuality. And when I said the word sexuality, the face became as red as your shirt. Literally, just kind of reddish purple. Some people have a real struggle talking about sex, and we don't know why. We don't know what their story is, why they can't talk about it.
Mm-hmm. Switching gears a little bit here, so Minnesota has had several well-publicized cases of nursing home personnel caught sexually abusing a resident.
Yes.
What is being done to prevent these occurrences?
Yeah, that becomes a boundary issue. So that's another whole area that we do a lot of teaching on, and there's a couple of good policies out there that I'm actually helping a facility develop a policy around that. But staff do really struggle with, even minor boundary issues that we'll call dignity violations that all of us experience. So that is, that goes, the sexual violations just go so beyond. Those are criminal acts. And that's just a byproduct of maybe, I often say the systemic attitude we have about aging in our society, that older adults aren't as valued as they should be because there's never been enough staff, there's never been enough training in long-term care facilities or maybe even in assisted livings.
And they're not well paid either.
Yeah, and they're not well paid. And that's not an excuse because these are criminal acts when they're, but obviously we've got to, that's part of the health department's rigid, review of these facilities, teaching boundaries to staff, being vigilant about holding staff accountable and monitoring practices, because it's sex is one thing, it's another to have the financial exploitations that might be occurring. It is just the immature development of people in our society that may be in healthcare, that maybe is in every occupation, but certainly, we need to do as much as we can, because I certainly am aware of those cases and see them too. What I train about is the same kind of thing I said about the soft signs around seeing a relationship develop. I talk about the soft signs for a facility when you have a staff member who goes behind a resident's door and closes it and there was no real reason to be in there. Or a staff member who's particularly friendly with a resident and seems to be doing personal things for them or takes them down to the laundry room for no specific reason. So I do talk about that a lot, about looking for soft signs and trying to stop these kinds of things. And then certainly as a psychologist, again, in the facilities where I go to, that's considered a crisis and an emergency. And then I go in and meet with the residents and really almost like a grief group and do trauma work to process that. But it's definitely an issue. It's definitely an issue. And, it's another side of sexuality that's actually criminal. And we haven't said that. There are situations where you have a spouse in the nursing home that may not welcome the spouse coming into the facility having sexual relationships with them. So again, that's a reason to talk about it, because then we're looking for injury on that resident, maybe because she's too medically fragile or he's too medically fragile. So there's that other side that we have to watch and have similar protocols around care plans. But certainly those employees should be dismissed, and the background checks and everything that are done, but you need to do a lot of supervision in those areas. And we're probably never going to entirely stop it. But,
All right. To anyone, a scenario. So a father still desired to be sexual and intimate. However, mother diagnosed with Alzheimer's didn't want to be intimate with the husband because she thought he was her father.
yeah.
Any suggestions on how to handle that in particular with both of them, the mother and the father?
Yeah, we know where mom's at, and she's maybe not capable of making a decision, but she thinks that's her father, and she doesn't want to have sex with her father. So this becomes more helping a husband, counseling, and that's a piece of what I would do is work with the husband, because you got to validate that. That's a whole set of emotional needs that maybe many of you as family caregivers in this room feel, everything from anger to sadness to grief to loss, your own sense of depression about the loss of a you've got a physical person there, but the psychological connection is gone. So that's another whole set of issues that family member needs support, and how do they get their sexual needs met without the intimacy with that person. And maybe they can tolerate touch, but they don't want kissing. They don't want, so maybe we can have some intimacy, but Mr. in this, has to go home and use things like pornography or, magazines or masturbation to meet his sexual needs. And I know many people who go out and have affairs. And that's another whole thing that we talk about. And that separation, because you want to do your duty as maybe a spouse, but you also want to go on with your life. And how do you balance that and be open about it and not judge it as right or wrong in the continuum of sexuality across their lifespan.
I think one of the things that we have learned in the past 15 years is that while many of us in this room do not have to worry about pregnancy anymore, many of us in this room, if we are having a new sexual partner, can get sexually transmitted infections. And there are hotbeds. Yeah, that's a good word, actually. No pun intended. Actually, I didn't intend that, but it came out that way. In both Florida and Arizona, in which the rate of syphilis, chlamydia, and gonorrhea have all gone up, and the largest population, the rate of change, not the actual number, but the rate of change is in people over 60. And so the villages, yes, I wasn't going to say the name. And so we have to think about that. And it was something that as a physician who specialized in menopause when I was actually working, women would come to me and say, well, I don't have to worry about getting pregnant. I do worry about getting sexually transmitted infections. And some people would insist on condom use and say, no condom, no sex. Other women weren't as strong in their resolve and would have sex without intercourse because their sexual partner didn't want a condom to be used. So
we actually see that as part of the lab work, as part of the joint consensual relationships that would be allowed. Checking out for STDs and doing lab work is just part of the treatment plan.
When my mother has moderate Alzheimer's, and when she gets ready for bed, and if she's awake during the night, she asks her daughters that are present to sleep with her. She comments that she is lonely after 6 years of marriage. Just laying by her seems to calm her. What else can we do to help her with her needs? She likes skin touch.
Large bed pillow, therapeutic dolls, massage, aromatherapy again, maybe hemp oils. There is a lot of fun things like that. Any kind of touch. We never lose the sense for touch. So, and if they're willing, that idea of just laying by her for a little bit, rubbing her arm, just even hand massages. What else can we think? Oh, fuzzy blankets, warm fuzzy pillows, colorful pillows, maybe even talking with her a little bit about her husband before she goes to bed. What else would ladies add from your own experience?
Hand massage, feet massage.
Beauty shop.
Yeah. I mean, we all know that infants will not thrive if they are not touched, and I think that is with us our entire life. So I would concentrate on touch of any kind that she appreciates and can always say no or yes, I like more of that, or I touch.
That's one of the things I've noticed with my dad, too. We weren't a real demonstrative family growing up compared to my in-laws. And so I only remember once ever getting a hug from my dad. Yet, since he's been in the home and we've had some of these issues, I make it a point to hold his hand wherever we go, put my arm through his, put my arm on his shoulder, touch him as much as I can during the day. And when he gets agitated, grabbing that hand really starts to calm him down. So I think the touch, no matter how small.
Soothing.
Yes.
Just your hand, just rubbing your hand can calm.
I think some substitutes can be too, like those dogs that now are anatomic, that they kind of bark or talk, and cats, that you can touch, because it's really the furriness that really can be central to your skin. So it does. You don't have to spend a lot of money doing some of those things, but they can really satisfy that need for touch, because that is really what we believe is the underlying biological drive for seeking out another person, is the continuous need for human touch.
For Catherine, can you speak or offer policy advice for disclosure of pedophile tendencies? A care facility discovered this history of a resident after a situation with an intergenerational activity. Does a policy need to be in place for assessment questions or background check, which would only show if behavior was reported to the authorities? This question is being asked with the understanding that this behavior is an expression of sexuality.
Are we talking about the resident being a history of pedophile?
Yes, the resident has a history of pedophile tendencies that was discovered when they did an intergenerational activity.
Yes, and I have to say, I don't believe as part of the assessment, because what happens is when a resident goes from one facility to another, that may not be known. And once it is known, we're usually checking background checks, and then a plan is put in place. There are some male or female units where we might try to transfer a person like that to, but there's definitely people who have that history, and I can think of some cases where I had where, I call them polar bears. These are people that everybody has to watch at all times. And again, maybe getting a psychiatrist involved or now getting better background information, but this person may not have demonstrated behaviors that would suggest they have to be discharged from the facility. So that's that balancing their rights as an older adult and their need for care, now maybe more medical than anything. But if it does show up, then we start, that they wouldn't be involved in some group activity. So again, that's probably gets to, we would definitely consult with any kind of probationary officer or the police department. Again, I try to, any one of these issues, it becomes, you don't want to be silent about it. You don't want to take a don't ask, don't tell. That would be my answer to that third question up there. We have to talk about these issues. There's too much of, don't ask, don't tell. Let's pretend it doesn't exist. As soon as you see a soft sign like that, get the whole interdisciplinary team on board and figure out a game plan that keeps everybody safe and involved. And generally, you can stay on top of this. And there's definitely people that have histories like that end up in assisted living in nursing homes, and they may have never even been prosecuted for that, or now because of memory loss and the disinhibition in its frontal temporal lobe dementia, where there's a lot of sexual disinhibition. So again, just get everybody on board, and usually we can keep on top of that population, but we don't want to ignore it.
We are 8 minutes away from being done. Time flew by. So I'm wondering if you each can kind of wrap up, give us you can answer the third question if you want. What concerns do you have about how things are going? What's going well? I also have a question. How can people get involved in advocating for the rights of older people related to sexuality and memory loss, or just in general? How do they get involved in advocating for policy to be created in nursing homes, or parents that want to have a room together, have some private time? Key takeaways, what you kind of want to sum up.
I have a concern, and now I have a new friend who works on policy. But the other thing is the Alzheimer's Association has a big policy department, Beth McMullen, and they are always looking for people to get involved. I'm involved with that. My daughter, who's 29, is also involved with advocacy and trying to get some policy in place. And we only know what to work on through experience and the stories. One of the things I still struggle with is consent. Because in the first instance with my father, after that, you saw the intimacy building, the two families were brought together, and we gave consent as long as there was no harm done, no fear, or any of that other stuff. As long as it was innocent and clean and that. When it happened again, I was told we couldn't give consents as caregivers. Even with the health directives and all that other stuff where I can make decisions, I couldn't give that because they were vulnerable adults. And so I'm still kind of confused as to what rights do I have if my father's engaging in innocent sexual behaviors or what appeared to be consensual between one resident and another.
I struggle, too, with the issue of consent. And the Iowa legislator is one of those instances. She was not verbal anymore, but she was always happy when he left. Not that he left, when he left. There's a big difference. We do not ask consent of these folks every time we feed them. Feeding is something that we need to stay alive, or drinking is something that we need to stay alive. Intimacy is something that we need to be whole. I struggle sometimes with the consent issue that you're talking about. And certainly we have to protect vulnerable adults. I have no question about that. But dementia, it doesn't happen overnight. It's this process. And at what point in the process can you not give consent, whether it be nodding your head, verbal, whatever? I don't know the answer.
I'm going to go back to touch. And I'm going to go upstream and say that these conversations need to happen upstream if they can. If you see signs, definitely these are conversations we have in our family. And I was reminded, maybe this is too much disclosure, but I was reminded about 10, I don't know how many years ago, Keith had a very, very serious surgery, and they didn't know if he was going to live. And our son, who is the geneticist, had come to Rochester to be with me, and he was in the hotel room, and I came into the hotel room, and he said, "How's Dad?" And I said, I don't know. I don't know if he's going to make it through the night. And I crawled in bed with my son, and we held each other. And I remember thinking how much I needed his arms around me and to have him next to me. It had nothing to do with sex. It had everything to do with intimacy and comfort and love. And I think that we underestimate that need for love and comfort, and that intimacy it can be incredibly intimate without being sexual.
Yeah. Mm-hmm. I think we know that to be true.
Yeah.
Anything else you want to say, Virginia?
The other thing is, sometimes I feel that in my condition, people project that I'm much more forgetful and much more incapable of cognitive thinking than I am. Right. And so, when they ask me, "How are you?" I never know what to say.
I think Virginia's correct, if I can, and I think you can be very powerful at your own level, starting with family meetings, your advanced care directives yourself. The clinic director where I work, he has advanced care directives that include being allowed to have sex with every woman that's interested in his memory care unit. And he's serious. He is like promoting this as a way of saying this is what he wants right now. So I think you can be powerful in your family meetings, in your couples meetings, based on what you want to take as you plan ahead for your life, and then through your advanced care directives. You obviously can go as individuals to the Ombudsman for long-term care to seek support and advocation at another level that can advocate for you within a nursing home. Then there's professional organizations like the Leading Age, the Alzheimer's Association, and care providers that are organizations that influence and teach. So there are, as well as going to your local legislators. So I think you can empower yourself and can have advocates out there that can support you at where you're at and where you want to go. And I do think there's a lot of unclear things, so having a sense that this may not be accurate and trying to even use the policies that you see in the folder today to kind of guide your work and look for other people that are considered sort of experts in the field to guide you, because Teri's right in the sense that anybody in assisted living or even long-term care are considered vulnerable adults, but that doesn't mean they don't have capacity for consent. That's a case-by-case basis, and it needs to be reevaluated consistently. So there is a lot of confusion, and it's very easy to just, again, go back to that don't ask, don't tell. You know, we don't talk about that here. There are definitely places that say we don't have that here. Well, that's not a place that you want to consider residing. Or, you know, do you want to be a teacher? Each of us, you know, we can decide that we maybe want to take this on as somewhat as a generational thing to change the way we view aging, which is kind of a role that I have. So I would just say don't give up and look for support, and again, be open and talk about it as a way to have respectful and safe relationships for yourself and others.
I'm going to add just one more thing, and then I am going to be quiet. I think that if especially younger people here go home and talk about this conference, you can bring up a topic, it can sit there, but once it's out there, it's planted. Mm-hmm. And that's what I would close.
Yeah, raise awareness, plant intent.
Yes.
Yeah.
I wanted to speak to every single one of you out there. Every single one of you is a sexual human being. You may not currently be sexually active, and you may be. Embrace your sexuality. Embrace it. It's really a core of who we are. And you as caregivers and caretakers for people with dementia, if you don't take care of yourselves, you've heard this before, I know you have, how can you take care of the person you're caring for?
All right, so on your slides, in addition to the handouts, I gave you, because there's just a lot of reading you can do, I gave you 6 additional links you can go to on the internet to find more information. Some of them are actually, Iowa has a lot of resources on the Ombudsman website, so go to those at your leisure. And this panel was gracious enough to give us their contact information, and I kind of spelled out who they are, what they're up to. In your slides, you have all of this. You have their book, you have email addresses, you have an idea of what some of their background is. They are willing to have you contact them. So will you please thank this wonderful panel with me?